Okay, I think we can get started. On the schedule, we actually have 3 people signed up to speak, although one person doesn't appear to be online or in person, so I'm not sure if she is still coming. Anyway, I would like to introduce our first speaker, Claudia. I will pass it to you. So, slides is sharing and then. Oh, yeah, okay, thank you. 10 to 12 minutes, and my watch will be when you're 10 minutes, so over 10 minutes. I'll try. I haven't practiced with that. It shouldn't be more than 10. So, no, thanks, Rola, and yeah, welcome to a very small and select audience today. Yes, Rola said, my name is Claudia, and for those who don't know me, I'm a senior lecturer in health economics. So this study I'm presenting today has been done in collaboration with people, with colleagues from the School of Cardiovascular and Metabolic Health. And I should also shout out to Giorgio, my colleague, who's done most of the very cumbersome analysis on this.
Apologies for interrupting. Is it possible to share the screen so we can see the slides online?
Oh, I'm sorry, I thought I had. Is that not? That's on there, but.
Perfect, thank you.
That's not mine. No. Sorry.
Oh.
Sorry, Ben.
No, I don't know if I can get anything. Oh, I'm going to be.
Yeah, we can see the slide saying study rationale now.
Thank you.
Oh, there we go.
Thank you.
So yeah, so moving on from introductions to the study rationale. So we undertook the study for kind of 2 reasons. So first of all was to see whether there's differences in people who are admitted to care home in terms of where they're coming from. So whether they're coming from the hospital or the community. The second one is to do a bit of data exploration in terms of what's possible with the routine data that's out there in Scotland. So over the last couple of years, there has been a real focus on social care and routine social care data with the establishment of the real research units and also the planned social care reform and creation of the National Care Service. Going down a little bit over the last few months. And this goes together with trying to transfer social care responsibilities from local authorities to a national service. So we know that what we do really well at the moment in healthcare is to use data to support decision making. And it's a very well established system. There's really good data out there to do that. But the data in social care is not so good, and we're not really good in using data to make these evidence-based decisions. And there's also no standardized system in the UK to record data on long-term care residents. So just to mention a few challenges in social care. So social care obviously includes not only the older adults, it also includes people with learning population here. Yes, I'm just listing a few, don't need to mention them all, but generally the system really relies very heavily on unpaid carers. There's usually problems in staff recruitment and retention. Social care commissioning is kind of focusing on costs rather than outcomes of quality, and there's a real lack of infrastructure or integration of services, stakeholders and sectors to facilitate data analysis. Sometimes there might be a willingness to share data. As I said, there's a lack of national data, so what we end up with usually is a very fragmented collection of local data sets. Also, the national NHS data are incomplete in terms of identifying those who live in care homes, and care home residents are underrepresented in epidemiological studies. So one example was COVID-19 that really brought to light where the problems are. So it really kind of exposed the data gaps, which had impact on research and also service provision. So the understanding of the pandemic was really impacted by lack of data and information on care home residents. So what we need really is data to be fit for purpose. So we need to understand where people are, what their needs are, and what their health outcomes are. But it's not really possible the moment to readily identify care home populations in national data. There's also lack of information on when people move between different facilities. So what happened during the pandemic with mortality recording was that the denominator for mortality is based on registered places in care homes rather than occupancy. So for care home mortality, it's a little bit unclear where and when people died, compared to mortality recording, as we know it from hospital records. So in hospital, on top of that, in hospital mortality for care home residents was also not well recorded during the pandemic. So what we ended up with was an incorrect numerator and denominator. But to rectify this, we really need to record care home residency across all national health care and welfare data sets. So what we were trying to do, so just to give you a bit of context where we are in terms of data when it comes to social care and in particular care homes. So our project aim was to enhance the data resource of the Scottish care home census through data linkage to explore the experience of individuals, their families and care providers. We had 4 objectives. The first one I'm just going to touch on very briefly was to characterize individuals who move into care home from hospital versus those who move in from the community to see whether there's any differences. And then also to quantify the resource use and costs for those moving into care home from the community. But we also wanted to use our methodological findings to inform future data collection in terms of a minimum data set and provide information guidance for practice, policy and research. So our study on different pathways into care home basically motivated by, there's a UK policy to avoid care home admissions from acute hospital settings. So the assumption here then is if people are being admitted from a hospital setting to care home, then this characterizes system failure. But it also ignores the differences and the different needs between people moving in from hospital versus the community. So what we did, we used the Scottish Care Home Census as a national data set. Data is slightly older, but this is due to how difficult it is to use this data set. So we have people moving in between April 2012 and March 2016. And we're also able to link to other data sources to enhance our information available. So these are just some of the, well, basically all of the data sets that we've used. We've got demographics, we've got SMR01 and PIS, and long-term conditions, and also SMR04. And then from those data sets, we were able to derive some of our predictors. We then split our cohort into 3 groups: admitted from care home, admitted from the community, and then there's a small, very select group of people who've been transferred to the care home from another care home. And then we looked at some of the outcomes that I've already mentioned in terms of mortality, stay, and also costs. So in our first paper, in our first analysis, trying to answer one of the first research questions, we found that people moving into care homes from hospital are clinically distinct from those moving in from the community. So if this is then true, then this may be reflected in the healthcare costs that they incur. And currently there's a bit of a lack in terms of studies focusing on resource utilization, with most studies looking at cost-effective certain interventions within care home settings. So as I already said, the Scottish Care Home Census has been linked to various health data sets, which allows us to distinguish between different partners into care. And this is just to show you that there's, in order to be able to analyze these data, there were really kind of some extensive manual efforts required, because we're using a census, so people appear in different years. So it's all kind of, it was a bit cumbersome to do, and we're not entirely sure people want to do that again or replicate it, or whether we want to do it again, but it's really not, it wasn't fun, and it did take us a long time. So moving on to estimating costs for those kind of moving in via different pathways, we were able to cost the hospital stays for people and also their care home stays. Without going into too much detail, so we estimated the costs using a 2-part model, adjusting for some of the predictors I've included here. And then in additional analysis, we looked at cost differences between groups for the 1-year period preceding and following care home admission. So just to show you some cohort characteristics split into the different routes of entering care homes, the hospital, community, and care home. So in our analysis, we tend to focus on hospital and community because the other care home group, it's a bit of a special case, and I think we want to mainly look at the distinction between the hospital and community admission. And there seems to be quite a difference, in particular when it comes to frailty for those people, so that's quite noticeable. So our estimated costs then, overall costs for people after moving into care homes, care home costs and hospital costs that have been incurred by people after they move into care home. So coming from hospital, around 24,000. People coming from the community, they had about 27,000 pounds in terms of costs annually. And then the other group coming from care home. We also looked at cost differences by different characteristics, so age, sex, client group, and frailty score. And what we observe is really very similar patterns in terms of age, sex, length and frailty score. So there isn't really much of a difference, and people coming from the community in each of those groups, they seem to incur slightly higher costs than those who are being admitted from hospital. So as I said, we've done some additional analysis as well by looking at the hospital costs before and after care home admission. So these are just hospital costs, so these are not the care home costs. And people, so hospital costs in the year preceding care home admissions were about £7,000, and hospital costs incurred the year after care home admission were at about £1,600. And there was quite a difference, as you can see, between the route of admission, so people moving into care home from hospital. They obviously incurred quite costs that were kind of significantly higher than those moving from the community, obviously. So in conclusion, my last slide. In conclusion, one can say from our cost analysis that individuals moving in from hospital and community have different needs, and this is also reflected in the cost differences that we've estimated. And a reduction in hospital costs in the year after moving in to care home indicates a positive contribution, we think, of care home residencies in terms of supporting those with complex needs. But there's also wider implications, as I alluded to in the beginning. So we really need to make sure that we operationalize recording of key information within electronic health records to make sure that they're really useful for us in terms of service evaluation, but also research without or with minimal additional effort. We also observe that there's quite an imbalance in resources for social care versus healthcare statistics. And it seems to be a bias favoring the availability and the breadth of health data versus social care data. And finally, I think that linking social care data to health data is promising, but requires targeted effort to operationalize meaningful information from care home and health records, which should be supported by adequate resourcing, infrastructure, and governance. So thank you very much. I probably went over time there, but
Thank you very much. Anyone have a quick question? Sorry, just a second. Let me turn on the microphone for the as well.
The people coming from the hospital have higher frailty, but they seem to have lower costs and when they get to the care home. That seems counter to what we would expect. Yeah, that slide, the bottom right. I would have done it.
so this is after moving into care homes. So frailty was measured at care home admission, kind of using data from before care home admission.
Sure.
And then, so this is once they've entered care homes. So, and these are costs, these are care home costs and hospital costs. So we haven't taken the costs apart into the different components for this one at the moment. So this is still ongoing, I should say. But I mean, it's not, I think it's not unreasonable to find that they have lower costs after they move in. So they might have higher needs or kind of more needs in terms of of care provided, but they might not necessarily have as many hospital admissions as other people. So, but what we can kind of dig into that a bit deeper.
It's super quick.
So I was just in, to follow up what Desmond was asking there, would the amount of time they might have lived affect the costs? Like once they moved to their care home,
So we
previously been in hospital, would that affect the cost because they may not
So,
be there so long?
so this is another point we're currently looking into. So we do adjust for mortality. So we do kind of have an indicator whether people die or not, and whether, how long they basically have time to kind of incur costs. But yeah, so that's again something we're gonna look at in a bit more detail.
Thank you very much. Thank you. Kate. You have your presentation on a USB or your email?
Watch it, the stick. I want to apologise. This is in my diary for 1 o'clock.
Oh.
Sorry if the colleague just said, well, somebody hasn't turned up. And I was like,
Sorry.
I have no idea why that happened.
So you pull that little one.
Yes. All right, it's computer, so.
Yeah.
Sorry if there was confusion. I know it did move at some point, but I assumed the calendar invite had the correct time. But I will double check that for the next one.
I thought there's quite a few people in today and it's whether there's anyone else that's got it.
Possibly. Yeah, sorry for that.
That's all right, at least I made it. I didn't want to seem as if I was uninterested in anything. It's actually
What we at now? How's that?
No, that seems to be.
That's just on the screen.
Oh,
That's just
not on
on-
Zoom,
yeah.
sorry.
Minimize it. Start that. That'll be screen one. So if you reshare, if you restart your slideshow. You can just close it then. Start it as it play on.
Oh, I'm sorry. Thanks.
Minimize that. Sorry. Well, let me just.
Yeah.
Then share this screen. So it's probably a lot.
Yeah, they're probably.
This one? That one? Oh, screen two, right, okay.
And then go up here.
Yeah.
Click there.
Before you start.
Thank you, Ben. Thank you. And I'm just like, I'm using over time. That's okay. At least I found out in time. But sorry to have missed the other things.
It's 10 minutes with a couple of minutes for questions afterwards. So when my watch beeps, that's 10 minutes.
Okay, lovely. So, thank you. For those who don't know me, I'm Kate O'Donnell. I work in general practice and primary care, and I usually try to be in time for meetings and not miss the other presenters, so I'm really sorry about that. I wanted to talk about some work which we did actually in sort of end of 2021 in relation to the pandemic, where we were asked to do some work around the digital tools that were being developed for contact tracing for use in Scotland at that time in relation to COVID-19. But actually to sort of extend what we've been thinking about in terms of starting to think about the equity implications for digital health interventions going forward, using contact tracing almost as a case study. So it's important, I guess, to remember going back to the sort of summer of 2020, when we were really in the thick of the pandemic, Some would argue we're still in the thick of the pandemic. But the drive at that point in time in terms of using contact tracing as a public health intervention, and really thinking about using that to try and identify people who had positive tests for COVID-19. At that point, you remember when you had a test, were being tested through a kind of government-run system. You sort of logged any positive tests that you had, and then you were required to self-isolate for up to 14 days. And really as a means of trying to break chains of infection, many countries, including Scotland, had tried to ramp up again the process of contact tracing to identify all contacts of someone who had been infected with COVID within a defined time frame. So usually sort of the prior 5 days or so to their positive test. And so the aim of this was to break chains of infection. However, there was a realization then, in fact, it came to bear fruit, that if the infection rates began to really ramp up, then they would have to find other ways of doing this beyond the more sort of public health or sexual health interventions of a contact tracer getting in touch with someone and going through all of their contacts. So we developed proximity apps to be used on mobile phones. And then the other thing that they were also keen in developing in Scotland, in particular at that point of time, was digital tools to try and help with this process. So the test and protect system in Scotland at that point, we had a proximity app on our phone. So if we were in contact for more than 15 minutes in sort of closer contact with someone who then tested positive, you were pinged as a reminder. There were contact tracers operating within NHS Scotland, drawn from public health, from sexual health and environmental health services, but also a whole group of new people who were recruited and trained into contact tracing at the time. And the other thing that they were developing at that point were these digital tools. So the idea that if you tested at home or tested within the system, that in order to cut the lag time as much as possible between getting a positive test and being contacted by a contact tracer, you could start that process by sharing information yourself. So you would get a unique code. There was a privacy statement within that came up to say that this was being held securely within NHS Scotland. And then it asked you to start putting in information about either people you had been in contact with or places you had been within a defined time frame prior to your positive test. And what they realised at that point as they were developing this was it was very likely that there would be groups who would be marginalised from this process. So NHS Scotland and the Digital Health and Information Centre came to us and asked us to do some rapid evaluation work about how people might view contact tracing tools, and particularly these being digital. So we worked with a number of organisations and key informants representing marginalised groups, drawing on the various contacts that we had and the groups we'd worked with. And we also had an advertised through social media for people to contact us directly. And through this, we interviewed 42 people. So we had interviews with 13 key informants. We had focus groups with 29 members of the public. And this was done at speed in a 3-month period in 2020. After we'd done our initial analysis and fed that back as they were developing and informing the development of these tools, we then conducted a thematic analysis, and we were interested in looking at issues of equity. So we used Progress Framework, which draws attention to these different characteristics, including race, ethnicity, culture, occupation, gender, sex, religion, education, and socioeconomic status. And we were particularly interested in these, and also in terms of urban and rural issues. So at that point of time, people viewed giving information in terms of contact tracing as a civic duty. And most people said that they would be very happy themselves to do this, but they certainly raised issues about particular groups who they thought might find this difficult. So particularly, for example, victims of domestic violence, that might be difficult for them. as someone said, they may not want to tell you honestly because the perpetrator may be threatening them. And that was in relation sometimes to seeing other people who they perhaps shouldn't necessarily be in contact with, or indeed actually being in contact with the perpetrator of the domestic violence when they were meant to be not seeing that individual. Trust was also a key issue that came out, and again, it was raised with a number of groups that many marginalised groups have a long distrust of official organisations, and that this was just another kind of official approach. So, for example, referring to asylum seekers, saying that people under immigration rules might find these questions quite worrying. Clearly, issues around digital and language literacy also came up. So there was a recognition that these forms and these sites, which at that point were only in English, really needed to be accessible in multiple languages. But also people needed to be proficient in digital access, and they needed to have the resources. They needed to be able to afford smartphones, they needed to be able to pay for Wi-Fi. And again, someone who worked very much with homeless populations said, digital exclusion is a reality and takes a number of forms. One is that they don't have access to digital equipment and they don't do business by email, and had the view that apps were really a phenomenon among a mobilised middle class. We also explored the issue of data governance and privacy. And we found there that the public respondents were generally quite trusting of the information they were given. And they had a high degree of trust in NHS Scotland, particularly as they were the custodians of the data. This was less clear in people who were key informants for multiple organisations, who felt that, again, that issue of trust was something that populations that they worked with had often been eroded. But everyone also felt that there needed to be clear reassurance about things like how long data would be held for, and also that data were not being shared with other organisations. We also discussed the wider issues, though, relating to contact tracing. And it was very clear that people felt there were real inequalities in relation to contact tracing. So there were dilemmas about sharing information about family or friends. Some people, for example, were very clear that they would share all information about people they'd been in touch with, but others were less sure about that. There were concerns about if, for example, you had been breaking the rules on the number of people you should be in contact with. At that point, it was down still at about only 4 or 5 people that you could be in immediate contact with at any one time. So people were concerned about how that information might be used if, for example, it'd been at a house party. And there was also stigma around testing positive. And this came up in some of our respondents in the focus group with minority ethnic groups, where they felt that some people, particularly older people, stigma would play a role in terms of them wanting to share information and say that they tested positive. And this also tied into the barriers around self-isolation. So there was recognition about both the financial and the wellbeing impact of self-isolation, that you really needed strong social networks to be able to help you through that. And there was a real concern about people who were self-employed or who were in 0 hours contacts, and about the practicalities of things like, for example, food delivery, or if you were living in overcrowded accommodation. So we found in this work, and I think there are still lessons to think about in terms of digital interventions more generally, that in this time, digital tools had a role to play within contact tracing. But it's really important to think about the multiple and intersecting inequalities that come into play. Trust was something that came out many times, and while many people trusted the system, there were lots of others who had good reason not to trust these systems. And that, again, we really need to think about these wider implications of poverty and digital exclusion, and to think about that from the beginning when you're actually designing digital interventions, and perhaps making sure that some of these frameworks, or sort of equity frameworks, are used in terms to help think through what the challenges are in some of these interventions going forward. Study was published in Health Expectations last year, and the work was funded through EHCI, the Scottish Government. Thank you.
Thank you very much.
So Marie, if we start online this time, do you want to highlight the questions? Is there any questions online?
Sure, I haven't got any questions in the comments yet, but if anybody would like to ask something, please feel free to unmute yourselves and ask a question.
Okay, if not, then we have somebody in the room.
Thanks, Kate. I find this really fascinating. My experience sitting in Malawi during the COVID pandemic, and I must have had 10 or 15 people from Oxford, Cambridge, Harvard calling up and saying, we need a digital contact tracing app for Malawi. Oxygen, we don't have steroids. I know. Anyway, I'd be really interested in your reflection. We focused on marginalized populations, but I guess the same issues may have come up with non-marginalized populations as well, particularly this big trust issue. And so my reading of the evidence of the pandemic with digital contact tracing apps had very little impact, very minimal at best. And even if you were to improve trust and reduce some of these inequalities, do you think there would still be a place for digital contact tracing in the next pandemic? Basically.
I think they probably had a role. It was less well used. It went through a kind of peak, so at the start of the kind of Delta wave, when the numbers really shot up, it was definitely used a fair bit then and did relieve some pressure, I think, on contact tracers themselves. But there was no doubt, because we know from other work that we did with contact tracers, that actually people really welcomed having someone getting in touch, that they could ask questions of. Things got unpacked often with the contact tracers that people hadn't wanted to put in. So like, well, actually I was mixing with larger groups of people that I wanted to see online. So I think there was quite a lot around that. I mean, they did learn a fair bit with the digital tools, but there was a lot of time and effort and money spent developing these, and really in the end, how much added value they got from, I think, compared to perhaps getting more contact tracers in and doing, getting in touch that way, I think was a difficult one to really assess. So I would say that for those sorts of things, it's probably still unclear just how effective they're actually going to be in those kind of situations.
One more quick question and then we have to move on.
There was actually a natural experiment that happened. Basically, the southwest of England converted its Excel spreadsheets from XLX to XLS, and basically lost a big percentage of their positive cases, and so they basically lost contact tracing, and that turned into higher rates of COVID. So that's not really digital, but basically it turned out that I don't know how much contact tracing costs, but it worked.
I think the personal touch clearly and that personal contact that people were having, it did seem to work. And even the people that they had brought in, the training was very good and they felt well supported. So I think they felt they were doing an important job at the time that it was running.
Thank you very much. We'll have to move on to our next speaker. Over to you, Ben.
Thank you.
Yeah, I hope that's sharing, but shout at me if not. Good afternoon, everybody. I'm going to return to the theme of healthy aging from earlier and talk about some emerging findings from a larger MRC funded project related to the influence of life transitions on mid to older age people's physical activity and social connectedness, and then try and think about that in terms of some systems-based intervention development. So a bit of background, life transitions, sometimes called changes, events. These things that happen in our lives, they could be natural, like bereavement, or social, like retirement. And these can change things for us quite substantially. Sometimes it's a good thing, sometimes it's a bit of a bad thing. But they're often considered an opportunity for implementing some health behavior interventions. And one reason for that might be a disruption to our habits, for example. It's worth recognizing that there are socio-demographic differences in terms of how people experience these life transitions and their effects on physical activity and social connectedness. For example, people from lower socioeconomic communities may be less likely to value physical activity at retirement, or if you are older or have less social capital to begin with, going through one of these transitions might likely to affect your loneliness in a bad way. And there's lots of additional barriers to behaviour change for us to consider in the ageing population. The literature in this area is largely focused on correlational studies with some qualitative research, but the impact on physical activity and social connectedness is not always that clear. A couple of examples again: physical activity in retirement, the only point where we see a spike in the life course of physical activity levels, and bereavement and physical activity, we don't really know the relationship really there. So what we've aimed to do in this study is taking that preventative angle, taking a systems lens, focusing on the experiences and priorities related to physical activity and social connectedness among adults aged 55 to 75 years, with recent life transitions, looking again at those potential intervention leverage points. There's been very little systems-related research in this area. I don't have time to go into what systems are and how they operate complex systems too much, but just a basic example here, thinking about things as a whole and the relationships between their component parts. So the bicycle is a system made up of lots of separate parts, but no single part operates it together. And that you can think about that in terms of the components of social systems. Thinking about things this way allows us to explore questions such as how the lived experience of older people in relation to social connections and physical activity change over time, what older people perceive to be the key contributors to these behavioural outcomes, how life transitions characterised as events in systems lead to changes in older people's physical activity and social connectedness, and then looking at some of those leverage points. So in terms of what we've done, we were looking to recruit people aged 55, 75, as I say, living in these two areas of Scotland, which were identified as areas of lower socioeconomic status within this age group. And people had to experience one or more of the following transitions in the last 2 to 5 years, being that retirement, bereavement, relocation, or taking on a caring role for a loved one. We did some semi-structured interviews, you can see online or face-to-face, and we've been compiling our framework analysis, comparing various themes in the data. I'll gloss over this, but you can see we've recruited 27, sample size of 27 so far, and we've had a pretty good distribution in terms of where they are, their gender, their age groups, and the transitions they've been through. Where we've struggled a bit is finding some of those lower socioeconomic participants, from more deprived areas, and we're doing some sort of top-up recruitment at the moment to address that through other parts of the wider study. So I'm going to go on to some initial results from the first batch of interviews, which is about 2/3 of the interviews, and I think this is one of our key contributions, I like to think, in terms of challenging narratives around life events, life changes as being static points in time, and there's still some very recent literature that would characterize them that way. They evolve over time, they're absolutely not static, and we can characterize them as events and systems in a number of different ways, we think, in terms of the multiple influences shown in blue, and the fact that transitions interact with lots of other different components in people's lives, often other life transitions. For example, we might move house when we retire, or we might be retiring whilst our loved ones or spouses or our partners are starting to care for their elderly parents and things like that. And so people have multi-layered experiences and have changes in their identities at these points in time, and we think there's likely feedback loops there, how people experience transitions that contribute to this ongoing experience. Around all of that, we've obviously got context, really important when we think about things in systems, especially the geopolitical context in this study, place, cost of living, strikes, divestment, things like that. We'd originally going to focus on COVID, but it was quite quickly apparent that that was too narrow a contextual focus, but it's still an issue, or was still an issue for some people we spoke to. And then the effects of all this can cascade around people and their individual environments. So moving on to some of the qualitative sort of findings here. This is a simplified and high level illustration of our current coding framework. And we're just going to focus on a couple of those in the interest of time. So the interaction between physical activity and social connectedness and the contributing factors perceived by the people we spoke to. So, as I say, we're interested in this synergy between physical activity and social connectedness. Transitions in our lives can break this connection between the two things, but it's also an opportunity to form new behavioural behaviours. So there are temporal aspects to people's experiences here. So if people were perhaps interested in team sport when they were younger, they're potentially more likely than people we spoke to enjoy group activities at a later time. So we might start to bring in sort of social supports, needs theories around relatedness and so on to help explain this. Of the people we spoke to, social connectedness and finding new social connectedness may increase physical activity opportunities for them in time, but we didn't necessarily have discussions about this the other way around. And we see this in caring roles as well. So people who, for example, are taking on the social roles and responsibilities, like taking your partner out in their wheelchair for some fresh air. The primary driver is not necessarily going to be the physical activity. It comes in time, and actually it's the shared interest and quality time together that people are looking for in those instances. And all of these connections between physical activity and social connectedness can be broken up by people's physical or cognitive abilities and the effects of the transitions as discussed. Again, we can think of social practice theories and things like that, but physical activity was discussed as a way of coping with some of these transitions, particularly in terms of mental health. So a couple of quotations here around some of the more beneficial things that can happen around life transitions. So this gentleman had locked himself away, he was bereaved, and it was creating those new social connections that he had opportunities to engage in physical activity in terms of manual labour here. Voluntary labour. And in terms of this gentleman was retired, and it gave him the opportunity to do things. But when we're thinking again about these things taking place in a system, there's the policy drivers here about their free bus passes and so on that allows people to connect and share interests and hobbies. In terms of the contributing factors then for physical activity and social connectedness, you can imagine there was hundreds of these really, if we coded them all up separately. And I'm just going to go through some of the more relevant ones related to that synergy that I've been discussing between physical activity and social connectedness and life transitions themselves. So first of all, people's relationships. So family responsibilities, relatives' needs, the health status of social connections, often related to transitions, particularly around caring, bereavement, and so on. Attitudes and existing behaviours of our social connections towards physical activity and social connectedness, and the fact that transitions can sever these ties, particularly retirement and bereavement, adversely affecting behaviours. In terms of supporting access to these opportunities, lots of practical considerations that people came up with, session times, costs, as you'd imagine, raising awareness of opportunities, and various psychosocial barriers, motivation, mood, esteem, etc., which can often be affected by those transitions again. And then finally, people's abilities and cognitions around physical, mental health, fitness, personality. Can they get access to the technology they need, to the aids they need for physical activity, perhaps any walking sticks, for example, and also something particularly important for this group increasingly is that access to healthcare professionals who have an understanding and knowledge of being active and connected as well, I suppose. So again, a couple of quotations to illustrate some of these contributing factors. People often spoke to us about the restorative role of nature in helping them cope with life transitions, the detrimental life transitions. The importance of local assets here. Somebody articulated how they were able to get something after relocating that they couldn't previously have in their old place. But again, we can think about are the local assets related to supporting people with transitions. The motivational mindset around function enjoyment was one of the key drivers here of behaviour. People really want to see physical improvements in their health, and there's some indication around social support through intergenerational activities. I think this might slide in a bit, but this is really quick. So we asked people around asked people around how they felt people could make changes to support physical activity and social connectedness. So we're drawing on ideas from systems thinking like leverage points from Meadows and so on. And we're building this into our community workshops as we speak. So recurring ideas in our conversation include shifting this mindset at a local strategic level, subsidizing services and opportunities, particularly to support around life transitions, investing in infrastructure, physical activity in particular, and addressing these vicious feedback loops that we see that are leading to disinvestment, disengagement, degeneration, particularly of our local town centres and so forth. And so, yeah, I'll conclude by sort of saying preventive physical activity and social connectedness interventions for healthy ageing will benefit from systems-orientated approaches that prioritise identified leverage points and consider how factors associated with coping throughout life transitions interact with broader systemic factors. So we're trying to break the bonds. Wider systemic policy contextual factors are important here. Mitigate any barriers and inequalities, particularly around different social groups, and then say disrupt and enhance the positive and negative feedback loops that inhibit or sustain physical activity and social connectedness around transitions. And I think that's me.
Well done. Any questions online? Feel free to unmute if you do. I don't see any questions in the chat. Okay, then we take the question in the room.
Thanks very much for the presentation. Just a kind of descriptive one, I don't know. Do you assume that there is any kind of overlap between the transitions? Because I mean, the transitions as they are at the moment, they seem that your approach seems to you assume that they are quite distinct, but there might be a kind of overlap between among all four, so people can relocate themselves because they moved first into a new environment, or the way around, or things like that. Have you noticed anything from your interviews that people can move to one transition because another transition happened before the age of 55, let's say, which is your starting point?
Yes, in short, certainly. I'd say, I wouldn't say majority, but a good number, maybe 50% or so. Yeah, so getting towards a majority have actually experienced more than one life transition. And I think we've tried to articulate that on that slide up now, but I tried to articulate on that interaction between the two green blobs, between the transitions on the first diagram that I showed. And actually people, through having the conversations with us, when we asked them to sign up to the study, they would tell us which of the criteria they met in terms of which transition, and then they would very much often say, oh, and then such thing happened, which we weren't aware of until the point of the interview, which had a knock-on effect. And often it was related to things like changing in health status and the people having to take on a bit more of a caring role and things like that, which I think because these things are happening to us and they don't necessarily happen as a single point in time, we transition through them and out the other end. I think this is giving people space to reflect on their experiences of life transitions, which without actually stopping to reflect and being directed through the interviews, they haven't actually ever done. So they've never really perceived these things as critical points. They're just getting on with life, if that makes sense. But yes, in short, there is definitely an interaction between the two. I think the examples we gave there just happen to be single transitions in the quotations, for example, bereaved man or retired woman, or we were picking out perhaps the aspect of the transition that related to the quotation. But I was going to check my data there, but I closed my Teams to stop the notifications. So, but yes, definitely. And there's definitely something we're looking to explore more as we develop the coding framework and look at the different experiences across the different transitions types and how they interact. Certainly, Thank you.
Thank you very much, and thank you to all our speakers once again. And keep an eye out for the next invitation for the next seminars. We'll double check the timing and make sure it goes into the calendar in the right place.
Will be 12.
It will be 12. At least for until the summer, after the summer break. Change that. But yeah, thank you very much.
Thank you all.
Oh,